Our speaker this evening was the Gresham Professor of Physics from 2018 to 2022 and Visiting Professor of Public Health from 2015 to 2018 and again from 2022 to 2024. He is the Chief Medical Officer for England and the UK Government's Chief Medical Advisor. Ladies and gentlemen, please join me in welcoming Professor Sir Chris Whitty.
It's a real pleasure to be here and a great honour to give the Sir Thomas Gresham lecture for this year. When Sir Thomas Gresham was alive and before he endowed this college, life expectancy was around 40 here in England and the wider UK. And this is a graph here on the right of all the years since then, right up to very recently, showing what the life expectancy of the UK has been. And really up until about the 1860s, my profession, medicine, took their fees but did pretty well nothing useful. And life expectancy stayed at round about 40 until that point. And at that stage, things suddenly shifted. And since about the 1860s, we've been on this extraordinary upward trajectory where life expectancy is now around double that of around 80 in the country. I'll come back to the last few years later on in the talk. But that is really the starting point for this talk. Medicine, public health, and general economic improvement have massively transformed health, and they will continue to do so. And it's very easy to think when you read the newspapers that things are going worse and worse every year, but actually if you take the long view, both backwards and forwards, I think we can see a much more optimistic picture. Now within this, there are three big drivers which tend to lead to significant changes in health. The first of which is demography. And health improvements significantly change the demographic structure of the country and of the world. And that in turn changes the diseases people have and what health can do. So there's a sort of circular interaction between demography and health. The second of those is epidemiology, the changing patterns of diseases. So the diseases, unsurprisingly, from when Sir Thomas Gresham was alive are utterly different to the ones we see today. But actually, over my clinical lifetime, the disease patterns, as we'll come on to, have shifted very significantly, and they're going to continue to shift very significantly over the next decades. And the third change, and these of course are all inextricably linked, is incremental, occasionally very rapid, but incremental improvements and changes in science, which mean we can do things in every year which we could not do in any previous year, and certainly in every decade that we could not do in any previous decade. Those are the three drivers which lead to the changes I'm going to highlight today. But throughout that, the role of medicine, of nursing, of allied health professions has remained in many ways constant. So if you take this famous painting of the doctor, what we can do now is very different to what was possible at that stage, and yet the fundamentals of medicine do remain the same. They do remain the care for the individual patient. Now, I'll start off with demography and childhood diseases around the world, because this is probably the most startling change, and when people look back over our era, many of the things we currently think are important will, I think, fall away, but these will be the profound changes that people will see. This is the demographic pyramid of the UK since over the last century. If you went back over 100 years, you'd have essentially a triangular demographic pyramid. The great majority of people were either children or young adults and had the diseases of children and young adults. As medicine has improved, people have lived longer through their middle ages, and the 1950s demographic pyramid we see here, with large numbers of adults of working age and children, but very few elderly people, is in fact what the NHS was designed to do. And in my view, many of the design flaws within the current NHS and particularly social care structure derive from the fact this was what it was designed for originally, and arguably has not fully transformed from. And then on the right, you see the demographic pyramid just before the pandemic and where we predict it will be with a high degree of confidence out to 2038. So that's actually not that far into the future. And the bar at the top is all people over 90 years old. but all the data before that are real data. Now, the reason we can be very confident about demography is because everybody in the world who will be 75 this entire century is already alive. So demography is a pretty reliable and slow-moving and predictable direction of travel. And this is going to change further for a very good reason. And this is one of two, in my view, very cheering, well, in fact, there are several very cheering, but this is one of the most cheering slides I'm going to show. This is under 5 mortality since 1900. And if you went back to that period, 40% of children would not reach their 5th birthday. And that has extraordinarily changed, much of that changed during the lifetimes of people in this audience. So on the blue arrow, what we have is 1900, and the red arrow is where we are now. That extraordinary change has irreversible and very positive implications, and we will continue to see a slide towards very low mortality in children. I'll come on to high income in a second. This is the global data. I'd like to look at this a few ways just to show why I'm confident this is going to improve. These lines here are all countries, and I've chosen them non-randomly because they happen to be countries I've had the privilege of working in. I could have chosen others. The point I'm making is that starting from very different positions in the 1970s, each one of them has child mortality going down to a very low level, and they're converging on a very low point. That is an astonishing achievement of medicine and of development, which I have to say the UK has historically played an important role in. Now, how has this happened? And there are several components to this. Some of them are old science and engineering, particularly water and sanitation. The science and engineering, epidemiology and engineering behind this really dating back to the mid-19th century and improved on, but not massively improved on really since. Then there have been a number of things to do with nutrition, which tends to improve almost automatically, but with improvements in agriculture more rapidly over time. But then there are the things which have had very big impacts, in particular, improvements in childbirth safety. Childbirth remains a dangerous period, but it is massively less dangerous than it was 100 or even 50 years ago, and the reduction in infectious diseases. This has come from lots of different routes, including, for example, malaria. I worked with many colleagues on malaria, where it might be bed nets and insecticides and drugs. Another very important group are vaccines. If there are any anti-vaxxers in the audience, look away now. But what you can see with each of these is the blue arrow where the vaccine was introduced for a major disease of childhood, and then what happened to the disease after that. Diphtheria. These are all from UK. Hib, which mufflers influenzae, which was a major cause of meningitis when I was a medical student and junior doctor, now virtually unseen. And rotavirus, more recently, a major cause of diarrheal disease around the world, which is very dangerous in young children, largely disappearing because of vaccines. So why am I confident this is going to continue? Well, it's because even with the existing tools we haven't reached everybody who could have improvements from better water, better sanitation, better nutrition, and better vaccines. And this is going to continue for the rest of our lifetimes. This improvement in global child health has been astonishing and remains astonishing. So now let's look at the wider part of the age spectrum globally, and I'm then going to narrow in on the UK, but I just thought it was important to set the global context. And this is a study where red is the number of people who died in the 1970, blue in 2000, and yellow in, green rather, in 2016, so just before the pandemic. What you can see on the left is children 0 to 4, which is the first set of bars, a stunning improvement. And then, actually, over all that time, really very low mortality in children above 5 up to about the age of 50. If you get through your first 5 years, your chance of reaching 50, even in the most difficult circumstances, are very high. And then a shifting to the right of mortality after that. But what I want to demonstrate with this actually is the robustness of humans once they reach 5 through to what I'm going to call middle age. After that, after late middle age, things become more driven by health for reasons we'll come on to. And that's a epidemiological way of looking at it. Let's look at it in an economic way. This is a famous slide which I've taken from the late Hans Rosling. What it shows is every country in the world with their income along the bottom and their mortality along the left-hand side. And what you can see is every country in the world is moving from the bottom left to the top right, converging in terms of where their mortality will be. And this will again continue for the rest of our lifetimes and indeed beyond. So we're therefore seeing a convergence to very low numbers in children and a convergence to very high numbers in terms of numbers of years lived around the world. And then finally, I'd like to look at this geographically before I look at a bit more detail. And this is the map of the world. And yellow is people who died under 50 in the 1950s. And the green and blue is people who die at a much later age. And as you can see, this improvement in mortality has happened absolutely everywhere. Apart from countries actively at war or with chronic crises, this is now the norm in every country in the world. So in almost every country in Africa, the probability of surviving to a good old age is actually better than it was in the UK when the NHS was founded. So that has been a transformation. Now, from this, many people took the view, perfectly reasonably, dating back to Malthus, that this was very nice and we don't want children to die, but this is going to lead to a massive number of children. But in fact, that is not what happened. When children stop dying, provided mothers are provided with education and contraception, the rates of fertility, the number of children per mother, go down really quite rapidly, usually to 2, roughly 2. And therefore, what we're seeing around the world is that global fertility has dropped very rapidly. Now, you can argue the pros and cons of whether that is a good thing or a bad thing. There's lots of philosophical questions about this. But from a health point of view, a mother having 2 children is much better for each of those children and the mother than what we were seeing, which was a mother having 8 children, which is seriously dangerous both for mother and for child. So this improvement will reinforce and is self-reinforcing. Every country in dark blue here now has a rate of fertility which is lower than the rate of replacement. So it is under 2.1. And therefore, in all those countries, the natural tendency is for the population now to shrink gradually, not suddenly, but that is the direction of travel. Very different, I think, to the way people had conceptualized it until quite recently. This is another effect of medicine. And in Africa, the rates are dropping very rapidly now. And the result of that is that the global fertility rate is going to cross the replacement level of 2.1 children per woman of childbearing age in the UN's view by 2050, in most people's view a bit earlier than that. And from then on in, the population is set to stabilize, and by the end of this century, the population in the world is likely to be shrinking for the first time in history outside of natural disaster. And it will go on in that direction from then on. So this is another major change that healthcare has provided and will provide. And this has quite big implications, not just for diseases, but also for the provision, for example, of doctors and nurses, which has relied on a very large continuous supply of young adults. This is going to shift, and we need to respond to that shift. Now moving on to high-income countries, and again, I'd like to start off with children. Fortunately, here in the UK, the data I've put up here for England and Wales, to be very exact, are low, but every death in a child is an absolute tragedy. And in 2023, the year for which we have complete data, there were in England and Wales 961 children who tragically died. Now, some of those were accidents, though some of them were things which medicine can do little about, but much of them still were things where medicine has the capacity to improve. And what I've shown here on the right are the rates, the causes, the most common causes of deaths, in this case, in children between 5 and 9 years. And in that group, the commonest cause of death is cancer, and the commonest cause of cancer is a form of leukemia, which I'll come on to. After that is accidents, and accidents become more important as children grow older, become more adventurous, go off on their own, doing the things which children and adolescents have always done and always will do, and rightly. So what's happened? So let's just take this important form of leukemia. This is the most commonest cause in children, acute lymphoblastic leukemia, ALL. And what this graph here shows, on the left is survival, what percentage of people are surviving, and on the bottom is the number of years since diagnosis, right up to 10. Down is bad. And what you can see at the very bottom is where we were in 1968 to 70. And at that point, we already had treatments. Before that, this was an incurable disease, and most children died very rapidly. And then the very first treatments came in. By 1972, the survival rate had gone above 20%. And then there was a big improvement in healthcare. That's one of the transformational steps in terms of the way these are treated. And then every decade, in fact, every few years, the survival of these children has improved. So we've now got to the point where the 10-year survival is over 90%. And now we can concentrate even more on making sure that the drugs, which have significant side effects, and the radiotherapy, which have significant side effects lifelong, have the fewest side effects and the least impact on a child's life from there on in. What this shows is the incremental improvements you see over many decades in health, taking the commonest disease in children 5 to 9 in this country. So medicine does progress, but often progresses in small steps rather than the large leaps that I think you would sometimes believe if you read the more excitable news stories. And alongside that, there are many children who have rare diseases. Each of those diseases is, as the name implies, rare, but actually, cumulatively, the number of children with these is actually quite high, and they may affect mortality and they may affect quality of life. I've illustrated this in this case with cystic fibrosis. This is a genetic disease which is particularly common in people of Anglo-Saxon origin. So it's very high prevalence in this country compared to other countries. And what we've seen is from a situation where most children do not survive till their first 4 years, every decade, steady improvements in survival. And these improvements are improving the whole time. So there's new classes of drugs have come in the last few years which are transforming the lifetime prospects of adults with cystic fibrosis, who previously really you'd have said 40 years was going to be high end of probability, now changing to much longer probability of survival. So here's an example again where the science chips away and one by one these diseases are affected. Take another one, for example, you probably all have read of improvements in our treatment of sickle cell disease. In another genetic disease, which is much more common in people of African heritage. So these are examples where science is chipping away at diseases in childhood, and that progress will continue. That is not to say that everything is going our way. In most physical diseases, the answer is they are on childhood, but I'd just like to highlight 2 things where there is reasons for significant concern. The first of them is childhood obesity. Children who leave childhood in living with obesity are being set up for a lifetime of poor health. Diabetes, heart disease, mechanical problems, several cancers. They have this because of the conditions in which they live and the marketing that companies do to them, those children and their parents, to try and get them essentially to take in more calories. And what you can see on this graph is on the left, children who are in their age 4 to 5 when they first go to school. And already you can see in the red line, children from affluent areas, and in the green line, children from the more deprived areas. By the time they get to the age of 10 or 11, these children have a very substantial difference between the areas of poverty, where the obesity rates are now high and rising, and the areas of affluence where they are much lower and stable. That, I think, is a social problem we should take extraordinarily seriously. It is completely unjust for any society to allow this to happen to children, in my opinion. And then alongside that, a growth which is not fully understood in the prevalence of people who are given a diagnosis of a mental health condition and of neurodevelopmental syndromes of different sorts. And this is something which is outpacing our ability to provide services, because the rate of increase in this has occurred at a much faster rate than the rate of provision of service. And this is a very serious problem for many children, older age children generally, and young people and young adults. So this is another area where the headwinds are against us. Now moving on to younger adults, and again for physical disease, but not for people with mental health issues. This is an area where things are getting better in many ways. I'm going to illustrate this with 2 groups of diseases. The first of these is cervical cancer. So cervical cancer is one of the acquired cancers. It's caused by an infection of young people, specifically young women, although HPV, the disease, can cause other cancers in boys and men as well. And what I've shown here, and this is a slightly complicated graph, but it's an incredibly encouraging one, which is the reason I wanted to show it. We've only just done the analysis, is these are different cohorts of young women. The very youngest here, they've not had long enough to actually develop the cancer, but the orange bar is people who were the first cohort to be given the vaccine. And you can see it tracking along until you get to this point, and then suddenly it starts to fall off a cliff. And cervical cancer is disappearing in that cohort of young women. And one by one, these other cohorts are going to turn over as the age of people who are vaccinated moves through the population. Now boys are being vaccinated as well, which will accelerate this. Here is a cancer which is heading, provided we keep our vaccination rates, for elimination over the next decade. That's an astonishing achievement. And then there's a very large number of extraordinarily disabling, not necessarily lethal, but disabling inflammatory conditions, ranging from inflammatory bowel disease, rheumatoid arthritis, multiple sclerosis, where we have a much better understanding about how the science works and much more importantly, still, how we treat them. And the treatment for these diseases is radically better in most cases than it was 10, 20 or 30 years ago. And it will be, as we move forward, better again. We are understanding how to target the particular bits of the immune system which are causing the problem and leave the rest of the immune system alone, which is really what you need to ensure people don't have a different set of problems caused by immune dysfunction. So here's a whole group of diseases where the progress for young adults is significant and will continue to be significant for the next several decades. So now I'm going to turn to older age because I think up to date, I think that the pattern has, with the two exceptions I talked about, been overwhelmingly a very positive one, where the future is going to be better than the past. And I can say that with considerable confidence. This is what do we do with diseases in older age? What is the direction of travel? How are we going to improve that? Life expectancy, as I showed you in that first graph, done over a several hundred-year timescale, has radically improved in the last 160 years. That improvement has continued over the last 40 years, but there was a significant slowdown around 2010. And you can see an inflection point where the rate of improvement started to slow down. This wasn't just in the UK, to be clear. This is in the great majority of high-income countries which have good data. And that almost certainly was associated with the economic crash which occurred around that time. It shouldn't be particularly surprising if we expect health to get better when incomes are going up. We should not be surprised if that tails off when there's an economic crash, and that is what we saw. Then, of course, we can see the significant impact of COVID, but that is now largely recovered. We're now, the last data we have suggests that just the life expectancy in the UK is a bit higher in this year, last year reported, than it was in 2019, and I can expect that to continue for at least the next 2 years based on current data. So we would again this year and last year and this year expect to see the highest life expectancy ever recorded, but only, in my view, by a fraction. But that is the direction of travel. This is the most important slide, though, I wanted to show you, because there is an assumption which is logical, including held by many of my professional colleagues in medicine, I have to say, that it is great that people are growing older, but if they're growing older, they will, by definition, have more disease, and therefore they'll need more healthcare, and they'll have less good lives. That assumption is wholly false, but it is widespread. And these are the ONS data for this. The total bar length is how long people live for, and the orange part of the bar is the number of years, an absolute number of years, where they're living with self-reported ill health. And the group of people who live the longest, who are living in the most affluent areas, who have the best public health, are the group of people who have by far, over a decade, less ill health during their lifetime. This is absolute amounts, not relative amounts. So actually, the group of people who live longest have the least ill health in overall terms. I know that's counterintuitive, but that is what the data show. And there are a number of reasons, in fact, why that is the case. So if, as people age, we can try and just compress this orange bar so that the top orange bar is like the bottom orange bar, we will immediately substantially reduce their poorer quality of life in older age, their dependents, and indeed what the state needs to do to support them in terms of health and social care. Everybody wins. And we know that we can do this biologically because the group of people in the bottom bar are exactly the same as the top bar, except they lived in a more healthy environment. That is the only difference. So without any more science, this is an achievable goal. And we can certainly do better than that, in my view, as science progresses. And the second reason that I am confident that this is achievable is because we clearly do have an upper bound of mortality. And that graph I showed you right at the beginning with Thomas Gresham is going to go top out and reach a high point and not go any further for the world as a whole. Now, where that is a matter of debate. But that is going to happen, I'm very confident about. And in the UK, at least, the lower down you are in terms of this graph, this is the second complicated graph, all the others are simple, promise. The lower you are, the more the improvement over the period 2000 to 2025. So this is over quite a short number of years. And if you're, for people who are in their 70s, 60s and 80s, there's been between a 20 and 40% improvement in mortality. And for people in their 90s, there has been essentially no change at all. So what this shows is we're pushing towards the bounds of the point where actually we cease to increase the number of years that led. Now, if we can delay disease, we can substantially compress this period where people have ill health. And what all of us want to be is in a situation where we're doing our favorite activities the last couple of days before we die, and then suddenly we don't wake up. That's it. And the way you do that is to push disease to the right. You delay disease. Because if you're going to diet, for the sake of argument, 90, and you previously would have got dementia or heart disease at 85, and now you get it at 91, you don't get it at all. So the key thing is don't have disease until you're dead. And that is an entirely achievable goal by pushing disease to the right. So you don't have to stop it completely, you just have to slow it down enough. The Grim Reaper meets you before the disease does. And that is something which it is entirely possible biologically to achieve for the majority of diseases. You can't stop them completely, you can slow them right down. And this is actually not just to do with individual diseases. And this is an important thing which I think all of you who have diseases of significance, are caring for people with diseases of significance, have friends and family with diseases of significance, what you'll be aware of is once you get one disease, you tend to get several other diseases in relatively short order. So most people either in this country either have no diseases or several diseases. Relatively few have one. And so each one of these needs to be pushed to the right. And we therefore need to take a concerted attempt to achieve that. And in my view, this is entirely possible. And indeed, we will achieve it. The only question is how far. Now, this is going to lead to quite a big shift in the geography of ill health in most countries, but I'm going to take the UK. On this graph, this is a well-known thing to anybody who studied public health. What I've shown is the prevalence, or how common at least, premature mortality, which I'm going to take for the sake of argument, is dying under the age of 75. And what you can see on that is it is very highly concentrated in this country, using England data here. And on the right, what I've shown you is the map of deprivation. They are essentially the same map. So if we can actually reduce the diseases of deprivation, this map will normalize, where it'll look very similar across the whole country. And actually, the diseases of deprivation are the easiest to sort out because we know that people don't have to have it, because people in wealthy areas don't have these diseases to the same degree. I'm only taking it under 75 mortality as a proxy for having ill health, significant ill health before your time. So it's not the age of mortality, although that's an important point, but it's a hard data point. Now hold that map in your mind, and now I'm going to move on to the map of people aged over 75 in this country. Roughly now, this is the latest ONS data, and where we project it will be with a high degree of confidence in 2043. And as you can see, that's a different map. That's in the peripheral part of the country. Places like London, where we are today, because they import youth, as most university towns, big metropolitan areas do, and then people tend to leave, typically in the UK after their second child, but at other points in their life, at other points are available. What you see is that the metropolitan areas will remain forever young, and therefore the rest of the country has to balance the equation. And the diseases of older age are going to be in the peripheral areas of the country, and that will change the geography of disease really quite profoundly. And this is predictable and going to happen. I'm not convinced we are planning for it. Now, why do I think that we can change diseases? Well, again, let's take the long backward view before I look forward. This is the last 100 years with the three major causes of mortality up until recently. From now on in, we need to add dementia into this group, but these until recently were the three big ones. And dotted line, infectious diseases, my own trade, and that really decreased very significantly over the first decades of this century, as they have been decreasing for many decades before. Then we had cardiovascular diseases, heart disease and stroke, and by the middle of the 60s, 1 in 2 people in this country was dying of heart disease, 1 in 2. And then that peaked, and that has been on a steady downward trajectory ever since that point in time. And then cancers look as if they're flat, but actually what's happening is different cancers are coming up and coming down. I'll come on to cancers in a minute. But what I'm showing you is you can change the pattern of diseases very profoundly if you try. The biggest of these, and the biggest one where the changes have occurred, but I think cancers will come soon, is cardiovascular disease. And this is just showing that this isn't just historical. So this is looking back to 1970 all the way through to 2022, which is the last data, just showing the last few decades with a 75% reduction in mortality from cardiovascular disease, an astonishing achievement. The general acute medical take that I see today is completely different to the one that I saw when I was a medical student, because cardiovascular disease has come down, has not gone, still a significant cause of disease, but compared to where it is. But like my previous area, highly concentrated in peripheral areas, and that's because where people who are older live and where people who are living in poverty live, particularly the coastal strip. So the geography of this is highly skewed. Now, how do we achieve that? And the answer is 3 groups of things, and we can do the same thing with almost every disease class. The first is primary prevention, things you do to the whole population before they even have any sign of disease. You're not saying you got high risk or you haven't. You're just saying to everybody, let's stop the big risk factors. And 2 very big ones for cardiovascular disease are smoking and often forgotten air pollution. Smoking coming down has been one of the great public health triumphs. And just to show you how quickly, people always say, oh, public health is lovely, but it'll take decades. So let me just show you. The pink bar on the graph on the left is when the indoor smoking ban was introduced. This is Liverpool accident and emergency, people coming in with heart disease. And what you can see is the 2 years that happened after that effect. You can see with the naked eye, you don't need to torture the data, what happened as a result of that single public health maneuver in terms of stopping heart attacks occurring. That's just one thing to stop smoking. And then you can also see on the right the significant improvements, although we need to go, in air pollution. So this has been one of the big drivers of this. That has not stopped. And if we can look here, I'm just going to do this because I think this is something which is going through Parliament at the moment. This is the rates of smoking at different ages from 2011 to 2023. That's 12 years difference. And what you can see is that people in their 70s and 80s have hardly changed their rates of smoking at all. I suspect quite a lot of them, if they were going to change, would have changed by then, and kind of take the view, well, you know, I am 85. Whereas in younger ages, very, very significant reductions in smoking, meaning that when they come on to be in late middle age and old age, they will have far lower rates, completely predictably, of heart disease, stroke, dementia, which I'll come on to, and many cancers. That is completely predictable. So that is where we're going to go as a result of this change, and the bill going through Parliament at the moment will hopefully, if the Lords agree with it, lead to a smoke-free generation. And the biggest driver of ill health we've had in this country, made for a small number of people having profits, let's be honest, that's what people have been killed for, is going to go away. That is an astonishing achievement of public health. Then the secondary prevention, where you say you have a particular risk factor, you've got high blood pressure, you've got high cholesterol, you smoke yourself, you're living with obesity, and you help people to stop those. I've illustrated this on the left with Willow, from which aspirin came. Aspirin, an astonishing drug, which has had an enormous effect on heart disease and stroke. People underestimate its power. I'll come back to that. Snake, from which ACE inhibitors, several of you may be on ACE inhibitors, that's where it originally came from, by several degrees, to be clear, you're not using snake venom. And then obviously helping individual people stop smoking who've got a heart problem. So that's this secondary prevention. And then the third thing is treatment. And some of the treatments have been extraordinarily successful, but most of them have been incremental improvements. I mentioned aspirin. I was right at the beginning of my career when this trial on the left came out, which demonstrated that a single aspirin tablet reduced the probability of dying from a heart attack by about 20%. This is a drug we'd had available in the drug cabinet in one form or another for decades, arguably for hundreds of years, depending when you put the starting point. So drug improvements have led to very significant reductions in mortality, and then we can now do things which our predecessors would only been able to dream of. So on the right, what I'm showing is what's called mechanical thrombectomy, and it's when neuroradiologists and others put a guide wire up into the brain when someone's just had a stroke, find the clot, put in something which for the sake of argument I'll call a corkscrew, and pull it out. And as a result of that, bits of the brain that would have died do not, and people can make a substantial and in some cases full recovery. An astonishing medical achievement, very effective, but you have to get there fast. And that's getting people to the procedure is probably the biggest barrier to its uptake. Now I'm going to move on to a disease which most people think is just going to happen, and I want to be a bit more cheerful on that, and that is dementia. And I wanted to make 2 points about dementia, the first of which is most people who reach their 80s will not have dementia. So the data demonstrate, for example, that 11% of 80 to 84-year-olds have dementia, which means by a process of not very difficult mathematics that almost 90% do not have dementia. And then the second thing, which I think is even less understood, is that a very high proportion of dementia is preventable, by which in practice we mean delayable to a reasonable age. And there's no single thing that will do it. It's lots of things which each reduce the risk by about 1 or 2%. But if you put 50, 1 or 2% all on top of one another, you end up with a very significant reduction. Now, many of these things are absolutely identical to the things which are going to cause reductions in both cardiovascular disease and indeed cancers. So smoking, alcohol, air pollution, obesity and inactivity, the 5 big things which you can do to improve things. And then again, things like reducing cholesterol, reducing high blood pressure, each of these reduce by a small amount, but cumulatively by a huge amount, the probability that someone will get dementia. And then there are some things which are specific to dementia, which include education, which is one of the reasons we expect the rates of dementia to go down, all other things being equal. It's because educational levels have steadily increased over time. And then some things which I think we don't take seriously enough. For example, hearing loss in middle age, if it's not corrected, is significantly associated with dementia, as is visual loss, probably at least in part because of social isolation. So these are all things we can do to reduce the risk. And you might say, okay, so how much do you need to do it? If we delayed dementia by about 5 years, we would probably reduce the dementia prevalence in this country by around 50%. So this is an extraordinary change, and we can do quite a lot of this using existing relatively simple interventions. Finally, in terms of the big blocks, and I just want to talk about a few things at the end, cancers. Again, my expectation is that the majority of these cancers are going to have a much better outlook viewed over the long term, and a significantly, though it's always incrementally better outlook, over the short term. So in this graph, again, unpublished so far, what we've shown is the changes in population mortality for many of the major cancers. If it's to the right, the mortality at a population level has gone up, and if it's to the left, the population the mortality at a population level has gone down. Population level means it's a combination of prevention and treatment. It's both combined. And in fact, in men, only one has gone up significantly, and that's liver cancer, and that's because of increasing rates of alcohol use. And in women, liver cancer again, and uterine cancer, which is associated with obesity. And almost certainly those two are causal. That may not be the full cause. In every other case, the population mortality from cancers has gone down, and in many of them, right at the bottom, for example, stomach cancer, the chances of dying from this at a population have massively reduced. In that case, mainly because of drugs against H. pylori, which is a bacteria of the stomach. It used to be a very common and highly lethal cause of cancer. Now, again, this is made up prevention, in this case, early diagnosis and treatment. Let's start off with prevention. A very high proportion of these cancers are largely or significantly preventable by relatively straightforward areas. Depressingly, the top of the leaderboard in terms of causes of death from cancer remains lung cancer by a long distance. Over 70% of that is caused by smoking, and quite a significant proportion of the remainder is caused by air pollution. These are remediable risk factors. We could really get lung cancer right the way down. It is still the case that in this country, if someone has a diagnosis of lung cancer, they have a less than 50% probability of being alive a year later. It's a terrible disease. But for many of the other ones, every one against which I put a red arrow, there is a significant thing we can do to reduce the risk. Not every cancer is amenable to this. For example, prostate cancer in men, which is one of the commonest significant cancers in men, there isn't a huge amount you can do to actually prevent the disease. But actually for most of the other ones, bowel cancer, breast cancer, for example, lung cancer I've talked about, we can make a very big difference. Then there's early diagnosis, and this is more important in cancer than it is in many other diseases. And the reason for that is the stage of disease you have, that's basically how early it is when you catch it, has a very substantial impact on what your survival and indeed how unpleasant the treatment is going to be. And our ability to diagnose cancer is improving the whole time. Some of these are blood tests, some of these are radiological tests, some of these are biopsies. So on the left, what we've got, this is a nice Cancer Research UK graphic, and this is looking at the 5-year survival. And even for lung cancer, which is at the top, 6 in 10 at the earliest stage will be alive 5 years later. Almost none will be at the latest stage. And by the time you get up to bowel cancer, breast cancer, or prostate cancer, you have an incredibly high probability you'll be alive and indeed well 5 years later if your diagnosis is in an early stage. So early diagnosis makes an enormous difference. And by screening and diagnosis, we can make significant improvements. I've just identified one area which is going to improve in the next decade, and that is the use of AI to read X-rays and to read histology. In its infancy, so this is from a paper which demonstrated that the AI that was reading a breast cancer mammogram was only moderately good. You'd be better off with a good radiologist. But that is going to change. And over the next 10 to 15 years, I would expect much of the basic radiological diagnosis to be done by AI. Initially, second read or first read, where it's one of the readers that's a human in the loop, in due course, probably completely autonomously for very many of these kind of conditions. And then there's treatment. And this is a Cancer Research UK slide showing on the left where the survival rate once you had a diagnosis was back in the 1970s, and on the right where it is now. And as you can see, very many cancers, that survival has improved very significantly. And I would expect improvements to continue in virtually all of them. Sadly, the bottom of the area, the ones which we've seen little improvement, are in fact the most preventable, which is a depressing reality. Smoking being the biggest cause. I'm confident that this treatment of cancer is going to improve in multiple ways. And I'm not expecting you to take in every area of the slide. This is mainly to make the point that actually this is going down lots of different areas simultaneously. So in cancers, depending which cancer it is, some combination of surgery. Basically, if you get an early cancer, for it's a solid cancer, and you just cut it out, that for most people is the end of the story. That's it. It's done. It's gone. Radiotherapy, an old technology, and chemotherapy, much of it dating from the 60s. Still highly effective, but it has significant side effects, as people are aware. Big breakthrough in terms of hormonal treatments. So for prostate cancer, breast cancer, big changes as a result of that, still improving. And increasingly, antibody-mediated treatments. Lots of what's called small molecules. This is just a pipeline of future drugs that are coming out for treatment of cancer. This area of research is moving incredibly fast, and increasingly immune therapy, where in this case, you take the brakes off the immune system and the immune system finds the cancer and kills it. That is going to transform cancer treatment for many cancers we have today. And possibly, trials going on in the UK today, vaccines. So I expect the future of cancer care to be very different in 10, 20 and 30 years in a positive way to where it is at the moment. But we shouldn't expect breakthroughs. For the great majority of cancers, there are a few exceptions. What you see is incremental improvements year on year. And what we've seen here is just showing colon cancer and melanoma. I could have shown many others. What you can see is the improvement happens decade on decade, year on year, but it's steady improvement. So what we're going to see is steady improvement everywhere rather than one or two big breakthroughs. Those are actually pretty rare. Infections I'm going to talk about less, except to note that we under research and underappreciate the effects of repeated infections in old age. And this is an area where I think we should be doing a lot more, but I'm just going to pass over that because I do think we can do better, and probably significant better than we are at the moment. Our ability to prevent and treat infections in younger age is extraordinary now. And we are getting some new things like, for example, better vaccines to prevent shingles in old age. Really very effective vaccine, but there is a long way to go. So in summary to that, and then I'm just going to move on to just three slightly different areas very briefly. We can do a lot to improve the situation in old age and for health in old age, and I'm very confident we will do so. I think there's an upper point of mortality. We can really compress the number of years people live in ill health, and that will be by a combination of prevention, primary and secondary, by early diagnosis for some diseases, for treatment to minimize disability, improve outcome. But also, finally, we must adapt the environment so that older people, particularly in the more peripheral areas where a high proportion of the population will be older, can have a good and independent life without requiring help. That's not a medical point, but it is predictable that people in their 80s will require, for example, an easier approach to public buildings than at a younger age. A point I'm not going to explore, but just to lodge, is that all of us will, at some point, probably get to a point where we may be teetering on the brink of having frailty and requiring help from others. And this is a problem which society in this country and many other countries has not properly wrestled with. Louise Casey is doing a review of social care in the UK, for example. That, I think, is an extraordinarily important area, but I think probably I'm not the best person to comment on it. Finally, two areas which are either predictably unpredictable or predictable but slow. The first is pandemics. We've just been through one. I've lived through two flu, a HIV pandemic, which was terrible. When I was a doctor in Malawi and Southern Africa, around 30% of my age group as a young adult had HIV. All of them went on to die. Astonishing impact on society. And we've got on top of it due to treatment with drugs, principally, and good and early diagnosis, reducing stigma. And then a pandemic which all of us have lived through recently, tragically, and again, enormous work by society led to reductions in mortality in the first two waves of this pandemic. There were societal impacts, but what then allowed us to have the mortality go down was vaccines. We were lucky to have a vaccine that was fast and effective in its development. And what you can see here is the mortality waves, the first two waves of COVID, the red wedges as the vaccine was rolled out in this country, and then what happened to mortality afterwards. It essentially went away. Don't let anybody say to you vaccines are not important in COVID. COVID has continued since then, mortality has not, and that is because of a combination of vaccine and repeated infection. And then the other long-term thing, which will have moved diseases around, its effects will be less in the UK than many other countries, but globally very important, is of course climate change. Finally, just some prognostication on science, and this comes with a very, very heavy health warning. Every single clever person I know who's told me what's going to happen to science in the next 20 years has been wrong. So aim off, but I'm going to give it a go nonetheless. Here are four areas, and then one big caveat, which I think are certainly going to improve our ability to manage health in the next 2 decades. We will definitely have better imaging. We're getting increasingly accurate ultrasound. We're having better non-invasive imaging. We're having better invasive but very small camera imaging. And AI, although overhyped, is going to have very significant improvements over time. The DNA and RNA revolution, despite having been there decades long, has still not run its course. We are still being able to do things with this astonishing insight, which we were not able to do previously, and that will continue. The immune therapies, both to damp down the immune system for diseases like MS and to use it as a way of addressing certainly cancers, probably some other diseases, by letting it off the leash, is going to be transformative in many areas. And robotics, although they are overhyped in some areas, largely because they're rather beautiful to photograph, as on the top, is going to make a very big difference to surgery, but also, I think, importantly, to things like social care. A different form of robotics, for example, exoskeletons, I think may be just as important as things that help with prostate operations. Possibly mental health, a little bit less clear. But I also would like to be really clear that, in my view, many of the best innovations in the next 2 decades will probably be very humble, will not reach the newspapers, but will be very profound. For example, something which someone who produced a better Zimmer frame to help people with mobility, someone who produced a better incontinence pad, may have a bigger effect on a larger number of people than someone who improved slightly on a clever robot. So it's very important we think of the less glamorous but extremely important areas of technological innovation. So these are the 3 major drivers. Demography, which I've talked about, profoundly shifting. It will shift in completely predictable ways. The epidemiology, which is changing as a result of changes in our lifestyle, but also the changes in medicine, and the improvements in science, which undoubtedly will continue to move forward. I probably won't have got all my bets right, but I will have got some. If you look at the causes of disease, going back to the bills of mortality, William Petty, who was Gresham Professor of Music here, one of the great polymaths as a Gresham Professor, was one of the founders of demography, and he would have completely not recognised the patterns of disease we've talked about today, because things have changed so much. These are the causes of disease in London, in this case back in 1664, a plague year. I think when Thomas Gresham made a professor of physics, made medicine one of the things this college should do, he was thinking about what could be achieved. I think if he looked at what has been achieved since his lifetime by medicine, I think he'd be very proud. And I think we all should be, about the amazing achievements I think societally and scientifically we've had to improve disease, and will continue to. Thank you very much.